everybody to this presentation. Welcome everybody to this presentation. This is our annual CEU presentation sponsored by Franciscan Missionaries of Our Lady University. And I have the pleasure of introducing our speaker for today. Amy Serio holds a Bachelor of Science in Dietetics from the University of Southwestern Louisiana and a Master of Science in Applied Life Sciences from the University of Louisiana at Lafayette. She has 17 years of experience in acute care and clinical nutrition management and has served as an assistant professor in nutritional sciences and the director of clinical education for the MS&S program at FRANU in Baton Rouge, Louisiana for the past 4 years. In this role, she is committed to educating and mentoring dietetic students in their quest to fulfill their educational and professional goals in the field of nutrition and dietetics. Amy has been enrolled in the Doctor of Clinical Education program at the University of Kansas Medical Center since 2022 and anticipates graduating in 2026. And before I hand it over to Amy, I just want to make an announcement that if you have any questions throughout this presentation, please drop them in the chat box. I'll be monitoring them as we go through this presentation, and we'll address any questions at the end. So without further ado, I'll go ahead and hand it over to Amy to begin the presentation.
Okay, thank you, Catherine. And I want to apologize in advance. I have been a little under the weather, so if my voice is a little raspy and I have to take a little water break here and there, that's why. But if you have trouble hearing me, just maybe put a note in the comments and Catherine will let me know. But I'll go ahead and get started. So today we're going to discuss nasogastric feeding tube insertion, the rationale, the process, and the technique. And this is just to serve as an educational resource to summarize this newer core competency for entry-level practice as a registered dietitian nutritionist. And this is just to note that I don't have any conflicts of interest and I'm not getting any kind of funding for this presentation. So the program learning objectives for today is to interpret the rationale of the 2022 ACEND Core Competencies concerning the RDN Scope of Practice. We're going to outline education and practice for this competency. We're going to describe the step-by-step process of tube insertion through the observance locations for the profession. So I want to give you a brief background on the function of ACEND, which is the Accreditation Council for Education in Nutrition and Dietetics, and why it's so important to all of us and to our roles as registered dietitians. So ACEND functions under the U.S. Department of Education, and it's responsible for establishing and enforcing standards for the educational preparation of nutrition and dietetics practitioners, programs that meet those standards. So in short, ACEND is the accrediting body for any nutrition and dietetics program that is going to produce students who are able to sit for the RD credentialing exam. So all programs that do produce these students must report to this agency, and they, among other responsibilities of the programs, we have to provide the education and skills necessary for graduates to function as nutrition and dietetics professionals. So the ACEND standards are updated every 5 years, and the latest update was in 2022. There are 8 standards in total, but today we're going to focus on Standard 3. And Standard 3 revolves around curriculum and learning activities. And it states that the core knowledge and competencies must be the basis on which the program curriculum and learning activities are built within the context of the mission and goals of the program. And then the subset of that, 3.1, is that the program's curriculum must be designed to ensure the breadth and depth of requisite knowledge and skills needed for entry-level practice as a registered dietitian nutritionist. So everything that we're doing must prepare the students for these specific core competencies and core knowledge. The competencies are in place through either didactic coursework, simulations, or supervised experiential learning, which some of you also know as rotations. So we're going to take a little quiz. So if you could all select your answer, or put your answer in the chat box, you can just answer 1, 2, or 3. Why is it important for nutrition and dietetics practitioners to understand the ACEND guidelines? So just put your answer in the chat and then we'll show you the answers. I don't know if I see any answers in the chat, Catherine, but I'll go ahead and tell y'all what the correct answer is.
I don't think we're able to click on it, guys. Oh, you just want us to put it in the chat, sorry.
Yeah. There we go. Thank you. So it looks like the majority of people are answering answer number 2, and that is the correct answer. Career in nutrition and dietetics. So let's just dive a little bit deeper into the question to understand why these standards are set, and they're set to prepare students for successful careers in nutrition and dietetics. So even though we're already in nutrition, we're already credentialed practice, because they not only impact new practitioners, but also us as seasoned professionals, as they ensure that we maintain the quality and relevance of our practices in the ever-evolving field of nutrition and dietetics. So whether you're in the clinical or education setting, this information benefits everybody in our field. So now we're going to move more on to the specific competency that we're focusing on in this presentation and kind of how it relates. Take a quick sip. So this specific competency, CRDN 3.5, explain the steps involved and observe the placement of nasogastric or nasoenteric feeding tubes. If available, assist in the process of placing nasogastric or nasoenteric feeding tubes. So as dietetic professionals, we all know the why behind the necessity of initiating enteral nutrition. So I'm not going to go over that and the necessity for the RDN to be involved beyond just that enteral nutrition prescription. So as RDNs, we're already conducting nutrition-focused physical exams. We're already able to order and monitor labs, order and monitor enteral nutrition and parenteral nutrition. So placing a tube and further managing that enteral nutrition kind of seems like that next advanced step. And the ASPEN guidelines and the Society of Critical Care Medicine guidelines state that early enteral nutrition is 24 to 48 hours of admission. And I'm sure for those of us who work in the clinical setting, we can kind of all speak from experience that that's not always the case, and that nutrition initiation does get delayed. I know from my experience working clinically firsthand, I've seen many delays that are preventable. So let's talk about a little bit about, so some of the whys are increasing nursing responsibilities. So the nurses have so many responsibilities on their plate, this, initiating the nutrition kind of falls down the line. Also nursing staff shortages and turnover, and then also a lack of training by nurses who don't often have of placing an NG tube or starting early enteral nutrition. So with proper training, us being able to complete this skill allows us to kind of counteract those whys that we just talked about in the previous slide. So how can we elevate our practice? How can we contribute to this, getting nutrition started early and being part of this endeavor? Timely enteral access placement and enteral nutrition initiation. Secondly, it helps to avoid the long procedures and verification prior to beginning enteral nutrition. And when I talk about this statement, we're going to talk about nasogastric and nasoenteric tubes, but because those are typically checked through fluoroscopy or other surgical means. And a lot of times that requires extra transportation to different departments to have the tubes placed and checked. And then our intervention could help with decreased costs secondary to less interventional assistance. So again, this applies more to a nasoenteric tube, but when you think about the cost or another similar discipline to place the tube, it's a lot cheaper for the hospital to have the dietitian do it. But I will say that radiographic confirmation is the gold standard, but that's not always possible. So that could result in even more delays in getting the enteral nutrition started. And a lot of the literature and the individuals I've spoken to in the process of creating this education have talked about without any kind of device to visualize the anatomy. And we can discuss more about that as we go on. And then lastly, our intervention can help to maybe reduce the unnecessary use of TPN. So we always want to avoid parenteral nutrition being chosen as an option over the enteral feeds when the gut is working. And just to circle back, again, where I talked about the nasoenteric tubes, there's limited data that showing that small bowel tubes being in. So whenever I talk about the tubes throughout the course of the rest of the presentation, I'm going to say NG tube, but I'm going to be kind of referring to both. Okay, so now that I've told you all this, you might be wondering, is it even in our scope of practice as RDs to perform this competency? And it is. So in 1978, in March, the standards of performance for clinical dietitians were first developed. And now last year in 2024 was the most revised scope and standards of practice for the dietitian. So per the Commission on Dietetic Registration, the scope and practice of standards are a comprehensive framework that describe both the minimum competent level of practice, as well as the depth and the breadth of practice in nutrition and dietetics for dietitians as well as diet techs. For nutrition professionals, which guide us in better understanding the practice environment, and it also sets the standards that guide our practice. They also serve to evaluate, to improve and expand our practices, and they help us to demonstrate and assure safe and quality practice for the individuals that we serve and the organizations where we work. And the scope of practice also serves as a key resource to understand the environment and the standards that guide our practice. So when you look at the scope and the standards, it doesn't necessarily mean that an RD is going to be able to perform every single standard in that scope of practice, but it does give us the option as dietitians, because there are more advanced skills with one of those. So it doesn't mean you have to, as a dietitian, be able to do this, but it gives you the opportunity and the guide to maybe have that resource and that option that you can safely and effectively learn that skill and learn that practice for your own individual practice. And there are several of those different advanced skills, and we're going to go over the NG tube insertion skills today. So the practice of registered dietitians being able to place intraoral feeding tubes started in 2001, and ACEND developed the standards of practice related to the specific nasoenteric feeding tube placement for the RD at the advanced level. So the advanced level, it could mean a dietitian that's certified in nutrition support. It doesn't have to be the case, but it always requires some specialized and extra training. And you can see on the screen here we have the guidelines for ACEND and then the revised scope of practice from the Academy. I'm going to take a quick sip of water. So what you see on the screen now is the most recent considered advanced practice. And I'll read the definition. So advanced practice is assessing and managing individuals with complex diseases or conditions. It requires specific knowledge, skills, and specialized training beyond core education and supervised practice. And then it gives you some examples of fairly limited to feeding tube insertion. You can see below in the snip of some of the other advanced practice guidelines that are there. And I just emphasize this to underscore that not just any RD can practice this. Even though we are training our students and in this practice, it's oftentimes, which in our case it is, simulations are being used, or it's just putting NG tubes into patients. So obviously advanced practice is still going to be necessary. A dietitian is going to need to practice the skill and be competent in it before they can go on and do it in practice. So everybody loves little Buddy the elf. And I just put this up here kind of as a joke, because in nutrition, I feel like there's always a lack of data or a lack of research. We're always searching for more. So that's kind of the case in this situation as well. There's a lot of students being trained in this NG tube insertion versus practitioners who are actually performing the competency. So I don't have any numbers to give to you, but we do know it's going on. And hopefully as as the practice continues, we'll get some more quantifiable data. So, and this is a big reason why we're not sending our students to, because there's not actually RDs out there that are performing it. So during my research for the presentation, I found the practice of the NG tube insertion to be very region specific. So not a lot of luck finding any RDs in our state or any of our neighboring states, actually. So why are we seeing this inconsistency? So we hear about RDs that are practicing the skills, but like I said, we don't see anybody around us that's using the skills. So the first is knowledge gap among preceptors. So some preceptors may just lack the awareness and experience regarding NG tube placement. And this kind of reminds me whenever we as RDNs started completing nutrition-focused physical exams, there was a period of transition before RDNs in practice were required to perform the physical exams in the workplace, but we were still teaching it to our dietetic students. So kind of the same thing with this. We know that the knowledge exists, we just aren't practicing it at this time, as a profession. Another inconsistency or potential inconsistency is in practice. So maybe people that are doing it aren't doing it the same. So while we have tools like this toolkit here on the left, this is the processes are still varying from site to site. So it's important to have that standardized training. So if you're interested in this, I highly recommend this toolkit. It's got a lot of great information, not just about how to place the tube, but also the reason behind expanding the RD scope of practice to include this skill. Another gap is education and training are necessary. And if nobody's practicing around us, where can we get this education? And other institutions step up and teach our preceptors and teach other dietitians what we're doing with our students so they can learn what these entry-level competencies are. And that's exactly why we're doing this today. And then lastly, there's always a hesitancy with dietitians. And I feel like, again, kind of going back to the nutrition-focused physical exams, For a lot of this, including myself, it was a foreign concept because learned when we were assessing patients then. And even I've heard some of my coworkers, I've heard other people say they've left nursing because they wanted to come to dietetics because they didn't have to touch patients, and then now with the NFPEs, we're touching patients, but it's become second nature, I think, for those of us that work clinically, and it's a part of what we do now. So I think the same will come with the insertion of the NG tubes. It sounds really foreign, but I think the more we get behind it and can, practice it, the better it'll be. So how did we get here today to educate you on this process when we, as educators, had no prior knowledge ourselves, as instructors? So we recruited our clinical learning coordinator here from FrainU's undergraduate nursing program, Rebecca Bergeron. She's in the two pictures on the slide. And she helped us to create a lesson plan for the simulation lab. And then she also served as the primary instructor for the lab for the students as well as for faculty. And the interns and us as faculty participated in the hands-on training in our CEU for short. And I'll touch on that a little bit on the next slide. But establishing interprofessional partnerships within practice also can lead to successful outcomes and advancements within our profession. So having increased awareness of the skills of the dietitian, especially those advanced skills team, and these interdisciplinary collaborations are also part of the RDN Scope of Practice. And then just kind of a side note, I've also seen instances in the literature when I was researching that sometimes speech language pathologists are also being trained to insert NG tubes. So I thought that was a little neat kind of caveat. Okay, so why simulation is an option. So it's a multidimensional practice that incorporates technology into interactive approach to practice critical thinking and patient care. So it's allowing students to practice skills outside of the actual clinical environment and can kind of help to bridge that gap between the education and that practical application. Standards of best practice, those are designed by the International Nursing Association for Clinical Simulation and Learning. And the standards emphasize that simulation-enhanced interprofessional education, or we also call it SIM-IPE, enables learners from different healthcare professions to engage in a simulation-based experience to achieve linked or shared objectives and outcomes. So now we're going to quickly move on to the demonstration, and it pops up very fast. So that's why I'm just warning y'all. And what we did, we had one of our students at the time perform the demonstration. So she's the person in the video. She's an alumni of our program, and go ahead and get it started.
Insert a nasogastric tube into a simulator. In 2022, ACEND began requiring all graduate dietetic students to explain the steps involved and observe the placement of nasogastric or nasoenteric feeding tubes, and if available, assist in placing these tubes. Today, we will review the steps to ensure a safe and effective insertion. Step 1 is to gather all necessary equipment. For today's simulation, we will need a nasogastric tube, a tape measure, water-soluble lubricant, adhesive tape or tube holder, sterile gloves, a 60 milliliter syringe, a cup for gastric fluids, and a stethoscope. Prior to tube insertion, the following dialogue is recommended. Hello, John Smith. My name is Emery, and I will be placing a nasogastric tube today. This will help provide you nutrition and medication. Do you have any questions before we begin? Let's ensure your comfort, and I'll start by placing you at a 30 to 45 degree. I'll now wash my hands thoroughly and put on clean gloves to maintain hygiene. Now I'll measure the nasogastric tube. We measure from the tip of the nose, over the ear, and down the xiphoid process. I'll mark the tube with tape or a pin at the measured length for proper placement. I'll apply a water-soluble lubricant to the first 4 to 6 inches of the tube to ease insertion. I'm going one of the nostrils, aiming towards the back of the throat. Please try to relax and breathe through your mouth. As you insert the tube, the patient may feel some discomfort or the urge to gag. If that happens, ask them to take a deep breath and relax. I'll advance the tube while asking the patient to swallow. This will help guide the tube down the esophagus. I will now secure the tube with adhesive tape or a commercial nasogastric tube holder to prevent displacement. Once I have inserted the tube to the marked line, I'll check for correct placement. Typically, this is where you would aspirate gastric contents with a syringe or listen for air sounds in the stomach. The next step is to document the procedure, including the size of the tube, length of insertion, placement results, and any patient responses. All done. You did great. Thank you for your cooperation today. It is important to keep your tube clean and to not pull on it. If you see any signs of complications, please let me know immediately. I will check on you regularly to ensure everything is going smoothly.
All right, so let's see if y'all are paying attention during the video. What size syringe was listed in the equipment needed to complete 3 or 4 in your comments? All right, it looks like everybody was listening really well. 60 milliliter syringe. Let's get some feedback on what you guys thought of our video. And I want to highlight a couple of important details from the video. And so again, talking about nasogastric insertion, 5-degree angle is usually used. So the patient can actually keep their head against the back of the bed. They don't necessarily have to lean forward or extend their neck. Excuse me. And then we're going to measure again from the tip bottom of the xiphoid process, which is the bottom end of their sternum. Some tubes do have gastric placement markers, or you can use tape and a pin, like Emery did in the video. And before you start, you can also ask the patient if they have a preferred nostril for insertion. Water to check for leaks. And also some tubes have lubricant already on the tip, whereas we place the lubricant on the tip. But the ones that are pre-lubricated, you just have to dip them into liquid. And then when you're beginning to insert the tube, it should be against the posterior portion of the nostril and parallel to the nasal septum, so that that hard part of the palate, which forms toward the ear of the patient. And then it's not necessarily going to be a comfortable procedure, but we want to avoid as much discomfort as possible. So just taking every step to ensure that the patient is comfortable. Discomfort. If there is resistance, whether it be coughing or choking, the tube can be rotated slightly. And you're asking the patient at the same time to swallow as you are advancing the tube. So it's kind of helping to ease the tube down even further with their help. Stethoscope to auscultate for any air present, or you can use that 60 milliliter syringe to pull up gastric content. And then typically the patient is sent down for a KUB just to check the placement of the tube. So going back to the nasogastric ask, and I'm including this in here because whenever I was doing this research, the guidelines kind of say nasogastric, but whenever I was tube feeding, so I just kind of wanted to differentiate that for you guys today. So some professional guidelines suggest gastric tube feeding or gastric feeding is appropriate at risk but not a concern. However, when you look at the critical care guidelines from ASPEN and the Society on Critical Care Medicine, they list the following factors that are associated with high aspiration risk. So patients over the age of 70, patients with poor airway protection, presence of an enteral access device, GERD, loss of consciousness, neurologic disorders, among a lot of other things. So you can add a lot of patients meeting at least one or more of the criteria for high aspiration risk. So they may be more appropriate for a nasoenteric or small bowel feeding tube. So a little bit of difference between the two tubes is that the nasoenteric tube uses a guide wire, and then the case with the nasogastric tube. And currently, there's no data supporting a difference in length of stay or mortality for those gastric tubes versus the small bowel tubes. The small bowel feeding tubes may be associated with lower risks of ventilator-associated pneumonia. And again, that's because of that aspiration. So, and also the nasoenteric tubes are associated with improved calorie and protein intake than a nasogastric tube. So now that we've kind of talked about the whole process, let's talk about the challenges and the benefits of actually adopting this practice at an institution. So first of all, of course, you need hospital buy-in. What as far as dietitians to be able to do this? Do you have an appropriate patient population and patients that are applicable to this skill? Excuse me. There's also training and observation time. Again, we talked about it being an advanced skill. So there's going to be time where dietitians have to observe nurses and they're going to have to train and do it themselves. There's ongoing competence and training. So just like other ongoing competencies that we have as dietitians or any healthcare professional, this would be one of those things. It's typically an annual competence. If dietitians start placing tubes, they're going to be required to provide that coverage. So that means coverage at night, coverage during the day. Excuse me. Oh, sorry. 24 hours a day. So if a patient needs to have a tube placed in the evening, then and it falls on the dietitian, there's going to have to be that kind of schedule worked out as well. And then the last challenge, dietitians, again, like we talked about, they don't want to touch patients. It's not something that they are interested in. And then a couple of other things to consider. Commission, of course, provides the clinical privileges as well as CMS. You have to make sure that you have your own state licensure regulations are in line and your own hospital regulations are in line that you're able. I am so sorry, y'all. And then also there's a RDN Scope of Practice decision analysis tool, if it's something that you are interested in. One other challenge that was noted when I spoke to, I have a friend in the DCE West Virginia and practices in Ohio, and she said a lot of times that the nurses felt like they were being encroached upon by the dietitians and maybe trying to like take some of their tasks, that the nurses weren't going to have as many responsibilities if the dietitians were to do that, and kind of leading to a lack of support from hospital administration as well. So that was kind of an additional barrier that's not listed on here. RD training to update job descriptions. There can be financial savings for the hospital, allowing for more prompt insertion of the feeding tubes, like we talked about at the beginning of the presentations, as well as x-rays and other types of diagnostic testing. And then it allows for a more standardized training process. So if you have a dietetic team that puts in the NG tubes, you have a standardized, needing whatever type of tube it may be. I'm so sorry. So one other thing I wanted to mention, going back to a benefit, the dietitian that I was telling y'all about, just were not having enough time, or there weren't enough interventional radiologists to be able to put in these nasoenteric tubes. So the hospital administration actually approached the dietitians and said, like, hey, we have this need, we know it's in your scope. And so they developed a protocol, interventional radiation, yeah, whatever. It saved them time, it saved money because it's a more expensive discipline than the dietitians putting in the tube. So, okay, so to finish things up, we can talk about what the future implications are for the dietetics profession. So kind of like about RDs having a hands-off approach. With this new skill that we're learning and we're teaching students as entry-level practitioners, they're entering the job market as a new RD with feeding tube placement skills, which is a highly desired qualification that some employers are seeking. Like I mentioned before, not necessarily systems are seeking dietitians that are trained in this. And then as you move on down the line and you evolve the role for the future of the profession, you can have an increased sense of professionalism. You're actually practicing at the top of the engagement, morale, and interdisciplinary fellowship. And then at the very top is your advanced practice RDN and specialist. And this can be, a good opportunity for clinical ladder and specialist positions and skills. And let me ask y'all one more quiz question. Finalize things and I can answer any questions you might have. So what is one of the challenges that RDNs may face? Yep, I think everybody's answered number 3. number 3 is the correct answer. We talked about those having coverage for the standardized protocol with your nutrition team, then you have to have that coverage around the clock. And I appreciate all of you for listening today. I apologize again for and these are my references. And I think Catherine is going to jump back on and moderate if anybody has any questions.
Yes, so thank you, Amy, so much for this wonderful presentation. We learned a lot about our new competency for dietitians. I hope that you enjoyed the video that Amy and our student worked on last year for, our teaching purposes and our training purposes. And that was something that we really enjoyed sharing with you all today. And so while Amy takes a couple of sips of water, please put in the chat if you have any questions. We have about 10 or 12 minutes, so we can definitely answer some of your questions that you might have. I don't see any in the chat right now, Amy, but I do have a couple of questions for you that I thought of as you were doing this presentation. So my first question is, you talked a lot about ACEND, and thank you for explaining what ACEND does and why it's important to the profession of nutrition. But can you kind of elaborate who composes the ACEND body, and is it a set of volunteer positions, or is it positions that dietitians are employed by?
So ACEND is governed by a board of directors. The core composition is volunteers. So it's made up of academic educators, also administrators. So they get, like, for instance, program directors from programs like ours, clinical dietitians from within the community. I think they also have registered dietitian technicians that sit on the board as well. So it's a good encompassing of, the variety of from our profession.
Okay, awesome. Thank you, Amy. Yeah, and I know that ACEND calls out a lot for dietitians to volunteer for various positions. And so if you are interested in kind of diving into nutrition education, I know many of you on the call are preceptors for our program or other programs. And so as a preceptor, you are an extension of our faculty, and ACEND is a great way to kind of learn more about your role as a preceptor and learning more about the education side of nutrition. Another question I had for you, Amy, you presented the video of Emory and completing the NG2 placement. And I'm a little bit familiar, but not terribly familiar, of other assistive technologies that are out there to, assist a clinician in placing NG tubes. So can you describe any assistant technologies that are available for bedside placement versus the blind placement that was discussed?
So the one that I am familiar with is CoreTrack. I don't know if anybody's heard of CoreTrack, but it's a magnetic imaging. So it's got a magnetic piece on the tube itself to be able to see as they're placing the tube, that magnet is picking up and showing on the screen. So I think that's kind of the gold standard, quote unquote, that dietitians who aren't doing blind placement are using those CoreTrack devices. Okay,
awesome. So we do have a question in the chat from Sheila Alford. She asks, do you know if added to an inpatient ORD's job description, do you see alignment with the salary/pay across the U.S. in hospitals that already have it implemented?
That is a good question. And I know that the dietitian that I spoke of during the presentation, they did get a bump in their pay, but I don't know exact numbers, and I don't know how that is across the board, across the country. But I'm going to look into that and try to find out more information.
Yeah, that is a good question, Sheila. I don't know if it's made it to Louisiana yet. So yeah, I don't have much research on it, but like Amy said, it definitely would, be interesting to look into that data just to further show the value of the dietitian, how we can contribute to the skill.
Right.
So another question I had for you, Amy, is one of our quiz questions was the size of the feeding tube, and everybody got that right. They were paying good attention to your lecture, so that's good to hear. But Can you describe, are there any other types of tubes that are used for placement?
So typically, you're using like a small, a single lumen small bore feeding tube. And what we are teaching the students on is the 12-inch French tube, which I happen to have one to show y'all. I don't know if you can see it with my background, but yeah, so typically it's a 12-inch French. The Dobhoff is used, but it's just for nasoenteric as well.
So Amy, also I was thinking we talked about Seth, and in the pictures and in the video you showed the mannequin, but can you tell everybody like the other types of things that we've purchased for our skills lab to help train our students in this discipline?
Yeah, so we also have they're called trainers. So it's basically like a headpiece. I guess Catherine, chime in if I'm saying it incorrectly, but it allows the students just to go in and place the tube in the nostril. It's just the patient's head, and it's got the nostrils with an opening in the back that allows I don't know what you call it, but it's like the patient's anatomy from their mouth like down to their intestine, and it's sliced in half. So you're like looking at the inside of the patient as you're putting the tube down. You can actually see the tube going down the patient's esophagus. All the feeding tubes, all the things that Emery showed in the video, we have all those supplies for our students to be able to practice on and to use those various methods like Catherine mentioned.
Yes, I think you did a good job describing all of our stuff in the skills lab. So another question for you, Amy. There, like I mentioned, are a lot of clinicians and preceptors on the call today. Do you have any advice for them as far as how they can begin to obtain this skill? Because, you know, some, if not most, if not all, have not been trained in this before. And if it is an expectation now or in the near future that dietitians perform this skill in the setting that they work in, do you have some advice on where they can go, resources that they can use to help them achieve this skill?
Yeah, I think starting with that toolkit that I shared from the Academy, that's a really good resource. It's got a lot of different information about places that have used the tubes or, you know, where to go to find resources. Also, kind of like what we did with getting a nursing, start with your education department and see if there's nursing educators that are willing to do that teaching with you. And then also, you know, US preceptors can reach out to us as well, and we can help to make those connections too. But I think starting out with your nursing educators is a really good place, and letting them know, again, like this is in our scope of practice, showing them these toolkits and just to, you know, further validate what we're doing, that it is in our scope.
Yeah, great advice. Also, Sheila is chiming in, and, you know, as an educational university where we are training future dietitians and are very privy to all of these skills lab and simulation technologies, she suggests you can offer training classes at free and use sim lab for local RDs. So what are your thoughts on that?
I think that would be a great idea. I mean, I think that that's kind of the purpose of why we're doing this today, quite honestly, is because people, I think if you don't hear it from us, you don't know that these skills are happening. Or if you're not a preceptor or you're not hearing it from the students, you don't realize that this is going on. So I feel like, yes, we are kind of we're the ones kind of in the trenches teaching and practicing this. So I think, yeah, it's a logical step.
And Amy, you didn't mention this, or I didn't mention it in your biography, but can you, and now that we're kind of touching on what we do at the university and our role in the skill and educating our student, can you talk about the in-depth simulations committee and kind of your role in that and some of the progress that we've worked on throughout the years to kind of highlight how, you know, FranU really is the subject matter experts when it comes to these clinical competencies?
Yeah, so we work, Catherine and I both sit on the simulation committee for in-depth, as well as we sit on our simulation committee here at FranU. So we're a big part of the interdisciplinary team here. And I feel like we're very valued as part of that team. We do grand rounds with our PA students. We do an ethics simulation with our nurse practitioner students. several other things. We're starting a sports nutrition lab where we're going to try to incorporate some of our, and then the national board that we sit on, we've just learning from different practitioners across the country that are practicing simulation and what they're doing. We completed a survey recently of just surveying where different institutions are as far as their level of engagement in simulation and what their willingness is to learn more. So it's definitely it's a growing field, and it's interesting.
Yeah, thank you. And Amy's been very vital to moving that committee forward. And again, that's another volunteer position. It's not through ACEND, but it's through the Academy of Nutrition and Dietetics, the INDEP, which is the Nutrition and Dietetics Educators and Preceptors group. So it is open to preceptors as well. There's a lot of volunteer opportunity, again, to get your foot in the door to really learn about all the educational roads that you can dive into. So we have a couple of more minutes. I'm not seeing any other questions in the chat. If you do have any questions, please jot them down now. But as we're kind of wrapping up, Amy, do you have any final thoughts or advice or, words of wisdom for the people that are in the chat today or on the call today?
I think just to be open-minded, this, like I mentioned before with the nutrition focused physical exams, it's a stretch for some of us to be thinking about this kind of skill, but I think it just further validates us and validates what we do as dietitians. So I think just be open-minded and be, willing to learn these new skills, because it can only benefit us as a profession and our patients as well.
Well said, Amy. I 100% agree with you. So this concludes our presentation today. We really want to thank our presenter, Amy Serio, for the information that she shared with us today. Also, everybody that participated in our live event, please look out for an email for your CEU certificate that will be coming from one of us in the next couple of days. And again, Amy, can you put in the chat your email address? Do you mind sharing that in case people want to reach out to you personally?
Yeah, and I did record the presentation. So if anybody wants a presentation or wants, I know I didn't have a lot of notes on the slides, but I can send you my notes separately if that's helpful.
Okay. Well, thank you all for coming today, and I hope you have a great rest of your day.
Thank y'all.
Thank you for joining us.